Hi, everyone. Thank you for joining us. Before Dr. Tandon begins his presentation, I want to let you all know about our student memberships. They are free and they can be renewed on an annual basis. Our student memberships with ACS offer annual subscriptions to both cannabis and cannabinoid research and the American Journal of Endocannabinoid Medicine, access to practical clinical handbooks, online video tutorials, and our members-only clinical library. There's discounted pricing to ACS medical cannabis educational courses and the certification exam, member pricing to ACS meetings and events, and there's opportunities for networking and membership with representation and cannabis advocacy efforts at the federal and local level. All of that is free for students. If you'd like to join the association, please reach out to us at info@cannabisspecialist.org. Sarah will be putting that in the chat. And then a little bit about our speaker today. Dr. Tandon is a native of Toronto, Canada, and a member of the board of directors for the Association of Cannabinoid Specialists. He completed his honors Bachelor of Science from McMaster University and his residency in internal medicine at the Frank H. Netter MD School of Medicine. He completed an additional chief residency year at the Hampton Veterans Affairs Medical Center and Eastern Virginia Medical School. Dr. Tandon then completed several fellowships in hospice and palliative medicine at Weill Cornell Medical College. He received additional pain medicine training at Memorial Sloan Kettering Cancer Center, as well as the University of Toronto. Dr. Tandon is board certified in both the US and Canada and is a fellow of the Royal College of Physicians and Surgeons of Canada. Dr. Tandon is an advocate for cannabinoid medicines, access, education, and research, who helped develop healthcare reform and public policymaking in Canada. In Canada as well as the US, he has given talks citing the available evidence-based literature on the use of medical cannabinoids. He is also interested in the use of psilocybin for medical purposes. Dr. Tandon currently practices as a medical cannabinoid consultant and palliative medicine physician. He is also a clinical site investigator, lead physician at McMaster University and the Michael G. DeGroote Center for Medicinal Cannabis Research. Dr. Tandon remains actively involved as a lecturer, training physicians at the University of Toronto, and has had a pioneering role in introducing medical cannabinoid education into the residency program curricula. That all being said, I imagine you're all as excited as I am to hear from him. So, Dr. Tandon, I will pass it over
The
to
evidence
you.
regarding medical cannabis use for disease and specific symptom treatment. So I'd first like to ask the audience members by way of chat if anyone can describe the plant species that is presented here. Feel free to type it in the discussion chat area in Zoom. So I hear some options there. Very impressive. Well, I couldn't hear that one, but I'm hearing some answers. Okay, and let's just take a look at the chat here. What else do I have? Similia. Okay, well, so this species is known as Digitalis purpura, or commonly known as foxglove, in which digitalis or digoxin is produced from. This is the drug that is commonly used to treat heart failure or cardiac arrhythmias, such as atrial fibrillation or flutter. Now, how about this alien-looking plant that is depicted on the left here? Any takers? Oh, Orlando, poppy. All right. Okay. So wonderful. This is in fact called Papaver somniferium, or commonly known as the opium poppy or sleep drinking, in which opiates like morphine and codeine are derived from and are commonly used in the treatment of pain. Now, what about the bottom two images here? Sure, everyone gets this one here. There we go. All right. Orlando's on fire, and he is right. This is in fact cannabis. So now what I find interesting from this exercise is a subtle observation that despite commonly using substances that are derived from the first two plant species for medical purposes, we are much more familiar with what the cannabis plant looks like, but rather may have a more limited understanding of the potential therapeutic properties that exist within it. Now, I'm not here to teach you about opioids or digoxin, but rather give you some basic knowledge about the cannabis plant and the cannabinoids within it that are believed to be medically helpful. Also, what's interesting is that the cannabinoid receptors, which we will come to learn soon, are the receptors in which plant-derived cannabinoids bind to. These receptors are known as CB1 and CB2, but specifically CB1 are very minimally, if at all, located in the brainstem. This is the pathophysiologic reason why it is not physically possible to induce cardiorespiratory depression solely with botanical cannabis. So first, some fun facts about the cannabis plant. The botanical family is known as Cannabaceae. The genus is Cannabis. With respect to the different types of cannabis species, which I'm sure many of you have heard of, such as sativa, indica, and sometimes forgotten ruderalis, this term refers to the broader classification based on physical characteristics, while chemovar is a term used to describe variations in the chemical composition of cannabis plants. It's worth noting that the distinction between cannabis species, sativa, indica, ruderalis, has been debated, and some argue that it may not be as clear-cut as once thought, especially considering the extensive cross-hybridization of strains over the last 60 to 100 years. Now, the chemovar approach provides a more nuanced understanding of the plant's chemical profile and has a greater relevance when speaking about its medical utilities. The closest plant relative to cannabis is our good friend humulus, which is the hop plant used in beer. Its origin is believed to be in Central Asia. It's an annual occurring herb that is considered to be dioecious, meaning that there are both separate female and male plants, and the dried female plants are the ones that produce buds, which have the highest concentration of cannabinoids found within the trichomes, which are small hair-like structures, which we will see a more magnified picture of later on. Now, before we get into the pathophysiology of cannabis, I always find it fascinating to learn about where and what this plant was previously used for around the world. And so, well before our most recent scientific discovery and understanding of how cannabis works within the body, many civilizations around the globe have been using it mainly for medical purposes. The earliest dated reference to marijuana was made in Chinese literature dating back to 2900 BC, and then in 2737, by Emperor Shenhuang, discovering the many healing properties with this substance, which was commonly being used to treat rheumatism, gout, and malaria. Then in 1500 AD, with the discovery of the Ebers Papyrus in ancient Egypt, which is reported to be the oldest complete medical textbook in the world, also mentioned cannabis as a treatment for gonorrhea, inflammation of the mucous membranes, and pain. Somewhere a bit closer to my home is that in ancient India, cannabis, or bhang as it is commonly known, still remains a popular drink in which cannabis is infused in milk and consumed. Even within the fourth book of the collective sacred texts of Hinduism, the Atharva Veda names the cannabis plant one of the 5 most sacred plants on earth. So a very special plant. In ancient Ayurvedic medicine, which also originates from India, cannabis was and is commonly used to treat epilepsy, digestive issues, muscle pain, and the varying symptoms related to related to leprosy. Similarly, in other parts of the world, cannabis was used in ancient Greece, Rome, Persia, now known as Iran, and Mesopotamia. While some individuals have speculated or made claims about the historical use of cannabis in ancient times, including during the time of Jesus in anointing the sick with oil, such assertions lack concrete evidence and are not supported by mainstream biblical scholarship or historical research. Though, interestingly enough, the picture that you see on the right here is a mosaic illustrating Jesus healing 2 blind men on the road to Jericho that is found within the Basilica Catedral de Santa Maria Nuova de Montreal in Sicily from 12th century. Now, this subject and debate remains quite controversial, however. A little more recently, and now closer to home, the Jamestown settlers from England brought cannabis to the USA in 1611 AD and was being used to treat depression and gout. George Washington, our good friend here on the left, as depicted, in 1750 AD, grew hemp for 30 years at his Mount Vernon plantation. He was quite intrigued by the plant's medicinal properties, and so he concentrated his efforts on growing a large production on his personal property. I kind of like George Washington a bit more now. In 1890, and the gentleman on the right is Sir John Russell Reynolds, a neurologist and personal physician of Queen Victoria. He used to prescribe cannabis tincture for the menstrual cramps experienced by the Queen. Also, not many people know about cannabis history in Canada, but in 1606, Louis Hebert, a botanist and apothecary, planted the first cannabis crop in what is now known as Nova Scotia, so East Coast, where I am today. When we look at other countries and civilizations around the world, the common theme about cannabis use was not of recreational consumption, but rather mainly for medical and a smaller part for spiritual purposes. When we further explore this local history of medical cannabis use in North America, we see that it was commonly used in both the United States and in Canada in the mid to late 1850s and early 1900s. In fact, a number of pharmaceutical companies that are still well known today, such as Eli Lilly and Company, had cannabis extracts as part of their available products for sale. Even in those days, Canadians were using cannabis extract for many common ailments such as chronic pain, poor appetite, migraine headaches, depression, and menstrual cramps. By 1916, our American colleague, Dr. William Osler, co-founder of Johns Hopkins, also documented cannabis as one of the best treatments for migraine headaches. Then, of course, like everything else that happens in life, politics, of course, happens. And so a number of drug reforms were placed into law in both the US and Canada that ultimately outlawed access and possession of cannabis products. And so, like the prohibition, both Canadians and Americans had to dump their beloved cannabis tinctures down the drain. Can you believe the madness? But then again, like everything else that happens in life, with time and the search for new discoveries, a second look into the medicinal properties and pathophysiology of cannabis occurred. Here we see a historical and comparative timeline of cannabinoids to opioids, including the rise and fall in interest of both of these substances. It wasn't until quite recently and in 1964 where THC was identified from the cannabis plant by a scientist named Raphael Mechoulam, who's considered to be one of the most prominent experts within this field. Although we now had physical evidence and a basic understanding of the chemical constituents within this plant that could potentially assist with various symptom presentation or possibly disease, we had not yet identified their mechanism of action. It was really only not until 2 to 3 decades later when we discovered cannabinoid receptors like opioid receptors, including that of endogenous cannabinoids such as anandamide, that are essential in understanding the entire endocannabinoid system, which we will soon learn. Then, over some time after the dust settled from all the debates, Canadians wanted access to cannabis again, like they wanted the return of alcohol. And so since I am Canadian, I thought it would only be appropriate to share a brief overview of the legislation of cannabis for medical purposes here. So aside from having excellent and top-notch whiskey and maple syrup, Canada reintroduced access to medicinal cannabis first in 2001 through a number of legislative changes. This was first through the MMAR, or Marijuana Medical Access Regulations, followed by the MMPR, then to the ACMPR, or Access to Cannabis for Medical Purposes Regulations, taking note of the word drop of marijuana from legislation, given that there is a historical negative connotation associated with this word particularly, and rather using cannabis more appropriately. This was then followed by the most recent bill, C-45 in 2018, which this bill is in fact the most recent law regulating access to both medical and recreational cannabis use in Canada. Now, how patients access medical cannabis, or also known as plant-derived cannabinoid extracts in Canada, is that they must first be assessed by a physician or nurse practitioner. If considered to be appropriate for therapy, a medical document is then provided authorizing possession of cannabis with a certain carrying amount and restrictions placed with respect to maximal THC concentration, including route of preferred delivery. The medical document is then sent to the licensed producer directly, which once received would allow the patient to register with the company, select the type of product that is within the confinement of their medical document, and then mail to the patient directly via courier service. The same goes for home grow and access to cannabis seeds with a similar approval process as shown on the right. The 3 main forms in which medical cannabis is available in Canada to patients is through dried flower, which may be either whole buds or milled products, Oils, either in bulk in a bottle or pre-packaged in capsules with a fixed amount, and most recently, edibles, topicals, concentrates, and beverages. Now, what this curve here illustrates is that as of 2023, there were approximately 400,000 medical cannabis registered patients in Canada. By the end of this year, this is expected to rise to over 450,000. Now, what we can take away from this is that there is a growing interest in cannabis use for medical purposes, especially among older individuals suffering from various chronic diseases. And if you already haven't had a patient ask you about possibly incorporating this into their plan of care, they likely will be soon. So that's why it's important to be well prepared by having a good understanding of the fundamentals of cannabis, or referring them to at least someone who may be more of an expert to continue supporting your patient's needs. Now, here in Ontario, there were approximately 181,000 registered patients in 2019, though these figures are a bit dated. When we look down south to my neighbor, medical cannabis is currently legal in 38 US states, 4 out of 5 permanently inhabited territories, and the District of Columbia. As of mid-2020, there were an estimated 3.75 million state legal patients, again demonstrating growing interests of medical cannabis access within the United States. And this is expected to further increase to approximately 5 million patients by 2025. So the interest is certainly growing, and it likely will with time as well. Now, out of the total number of physicians in Canada, that being 75,000, approximately 7,000 of them are prescribing cannabis for patients, mainly to assist with chronic pain, neuropathic, and cancer-related pain symptoms, followed by some of the other symptom presentations or disease here. Within the United States, prescribing trends are similar to here in Canada, that being mainly for chronic pain, followed by a number of other conditions as listed here again. Now, many of you might be wondering where medical cannabis comes from in Canada. Well, I can really assure you it's not from our good friend Pablo Escobar here, although he might be pretty fun to hang out with, but rather cannabis in Canada is mainly cultivated, processed, and sold for distribution by licensed producers who have been authorized by the Canadian government and Health Canada to do so. This here is just a short list of the 102 authorized companies in Canada that produce medical cannabis products solely for either produce medical cannabis solely versus others that produce both medical and recreational. Now, what we see here is a real product sample display of how cannabis is available in both dry flower or bud as seen in the red container, followed by bulk activated oil in the middle yellow bottle, and pre-packaged oil capsules within the blue bottle on the right. The color bands across each container correspond to the type of cannabinoid and concentration found within each product, as evidenced by the color legend on the left. The red band indicating a predominantly THC concentrated product, whereas the yellow indicating a dominant CBD product, and the blue being in the middle and considered to be a balanced or relatively equal 1-to-1 THC to CBD product. Again, as mentioned, the Canadian government regulates and permits licensed producers to produce and sell cannabis products to either the medical or recreational markets or both. Now, moving on and to the fun stuff, we must first define and learn a few basic concepts of how cannabis works within the human body. The endocannabinoid system, or ACS as it is commonly known, firstly is a comprehensive and complex homeostatic balancing system with diverse potential therapeutic clinical implications in chronic conditions. The ultimate function of the ACS is homeostasis, which is returning balance in the body. It is the internal biological balancing mechanism of the body and brain. The key functions of the ACS in promoting homeostasis can be remembered by the acronym PREX, or protect, relax, eat, forget, and sleep. The ACS also changes as we age. It's different in every person based not only on age, but also on race, gender, and the use of pharmacotherapies that can tip the balance away from or help restore homeostasis. The fundamental pillars of the ACS consist of the following. Endocannabinoids such as N-arachidonyl ethylenamine or anandamide and 2-arachidonyl glycerol, or also known as 2-AG, are produced in the body on demand and act as partial agonists at CB1 and CB2 receptors. Activation of these receptors by anandamide and 2-AG has the potential to modulate anxiety, stress, inflammation, pain perception, appetite, and sleep, among other processes. Exogenous cannabinoids such as 9-delta THC, CBD, CBG, etc., which are plant-derived cannabinoids or phytocannabinoids, are also part of this system. There are also synthetic analogs that are produced within the lab, both legally and illegally, such as nabilone, dronabinol, and K2 or spice, respectively. And then CB1 and CB2 receptors, which we will shortly learn more about, are also an integral part of the ACS system. Lastly, enzymes produced in the cerebrospinal fluid drive the biosynthesis, degradation, and transport of endocannabinoids, and other ligands that act on cannabinoid receptors are also part of the ACS pillar. Such enzymes include the following: N-acylphosphatidylethanolamidide phospholipase D, or NAPE, PLD, DAAGL, PLC, FAAH, or fatty acid amide hydrolase, or MAGL. The main active ingredients in cannabis are referred to as plant-derived cannabinoids or phytocannabinoids, and are also called delta-9 tetrahydrocannabinol and cannabidiol, commonly known as THC and CBD, respectively. They are the most well-known and studied cannabinoids, but there are well over 100 different cannabinoid compounds within the cannabis plant. Each compound offers its own array of medicinal properties. What we see on the bottom left is a picture of a cannabis plant with some mature buds, evidenced by a majority of milky white to amber colored trichomes. On the right, we see a magnified view of the same image depicting these elongated glandular-like structures known as trichomes, which harness the highest concentration of cannabinoids, including THC and CBD. These trichomes are most abundant on the buds of the female cannabis plant. The resin produced by the trichomes contains not only the cannabinoids, but also terpenes and other compounds that contribute to the therapeutic and psychoactive effects of cannabis. When people consume cannabis, whether by smoking, vaporizing, or using other methods, they are primarily ingesting the cannabinoids concentrated in these trichomes. Cannabis plants vary by morphology, odor, and chemotype, producing plant resin with varying ratios of pharmacologically active cannabinoids, principally THC and CBD, terpenoids, flavonoids, and other molecules, as we've now come to learn. Terpenes may have a direct physiologic effects, as well as interacting with cannabinoids to create this sort of unique effects of individual cannabis cultivars. Additionally, it is important to consider the entourage effect of cannabis, which is the theory that terpenes, flavonoids, and cannabinoids all work together like a symphony. These components all complement each other so that you can get the maximal effect of the plant. Terpenes are essential oils, essentially, that provide aroma and flavor to the plant, whereas flavonoids provide pigment and potentially antioxidants. There are many terpenes that we already consume on a regular basis that are found in other plants, such as citrus fruits like lemon, orange, lavender, pine, thyme, to name a few. And they serve biological purpose in these species, such as attracting pollinators, warding off predators, and helping plants recover from injuries. Scientists have identified hundreds of different terpenes, in which the cannabis plant alone contains over 100. This here just illustrating the entourage effect, and one of my favorite shows. Now, THC and CBD exist in the raw plant, mostly in their carboxylic acid precursors, delta-9 tetrahydrocannabinolic acid, or THCA, and cannabidiolic acid, or CBDA. Inactive THCA and CBD are converted by decarboxylation to the neutral phenols THC and CBD that interact with the endocannabinoid system. The simplest and fastest way to achieve this is by heating raw plant material, either by vaporizing, smoking, baking, or cooking. And thermal decarboxylation of the dried cannabis flowers is a step that is often integrated into the production process of many commercially available cannabis oil products to ensure the cannabinoids in the finished product are activated and ready for oral consumption. Taking a closer look at cannabinoid receptors as part of the endocannabinoid system, CB1 and CB2 receptors are G protein coupled receptors upon which a majority of other pharmacologic therapies also impact, are produced in the body as a result of human evolution. CB1 receptors are ubiquitous throughout the body and are predominantly found in the central nervous system with a high density in certain areas of the brain, for example, cerebellum, globus pallidus, hippocampus, and substantia nigra, whereas CB2 receptors are mainly limited to the periphery, including the immune system. Understanding the activity of CB1 and CB2 receptors in the ECS, ligands, as well as enzyme synthesis, release, and degradation is needed to understand the diverse therapeutic clinical implications of medical cannabis used in the treatment of chronic conditions. Aside from CB1 receptors being predominantly found within the brain, they are also found in adipose tissue, liver, muscle, the GI tract, pancreas, as well as reproductive and cardiovascular tissues. CB2 receptors are highly abundant and primarily confined to the immune system, including T and B cells, the spleen, and tonsils. When looking at how phytocannabinoids interact with these receptors, we can see that THC mimics the effects of anandamide and 2-AG on CB1 and CB2 receptors, and CBD may rather indirectly activate CB1 by modulating these receptors by way of engaging with other endocannabinoids, ion channels, enzymes, as well as receptors beyond the ECS system. Although other receptors play a role, the majority of the effects of THC from cannabis are mediated through partial agonism of central and peripheral cannabinoid receptors, CB1 and CB2 respectively. Activation of CB1 and CB2 directly inhibits the release of multiple neurotransmitters, including acetylcholine, dopamine, and glutamate, while indirectly affecting GABA, NMDA, opioid, and serotonin receptors. Another way to understand the complex pharmacological interaction of cannabis and its cannabinoids within the human body is by way of the lock and key metaphor, where CB1 and CB2 receptors are the locks, and cannabinoids, either endogenously produced or exogenously introduced, are the keys. We can see by both CB1 and CB2 signal through the transducing G proteins and their activation by THC or other agonists causes the inhibition of adenylyl cyclase activity, the closing of voltage-gated calcium channels, the opening of inward potassium channels, and ultimately leading to the suppression of neuronal excitability, which could result in decreased pain perception, as an example. When further exploring CB1 receptors, they're the most abundant G protein coupled receptors in the CNS and are found in the highest concentration in the central and peripheral nervous system, including the GI tract. While present throughout the CNS, it is important to note that the concentration of cannabinoid receptors is low in the brainstem, specifically the area responsible for cardiorespiratory drive. Thus, it is almost impossible to cause cardiorespiratory depression and death using cannabinoids. This, of course, contrasts to opioid use due to the high concentration of mu-opioid receptors in the brainstem. CB2 receptors, on the other hand, are found primarily in the immune system, including the tonsils, spleen, lymph nodes, and circulating lymphocytes and neutrophils. The activation of CB2 receptors in the immune system inhibits cytokine, chemokine release, as well as neutrophil and macrophage migration. This gives rise to complex modulatory effects on the immune system functioning. While mostly found in the immune and other organ systems, research suggests that CB2 receptors are found in the CNS in lower density and may play a role in neuroinflammatory modulation. Lastly, cannabis has not been demonstrated to be associated with increased risk of infection and does not seem to do much to the normal immune system, but rather reduces hyperactivity, which may in fact be helpful in treating conditions like Crohn's disease or ulcerative colitis. CB2 agonistic receptor activity at the neuronal level is shown to be protective by decreasing pro-inflammatory molecules that would otherwise damage them. And this is observed by seeing a decrease in TNF-alpha release, nitric oxide, microglial activation, to name a few. When examining the CNS histopathology, we see an abundance and high density of both types of cannabinoid receptors, but predominantly CB1 within the periaqueductal gray, thalamus, and dorsal root ganglion regions, which are involved in the pain neural matrix. With respect to nausea and vomiting regulation, CB1 receptors are highly concentrated within the dorsal vagal complex, which includes the area postrema, which promote nausea and vomiting. Moreover, CB1 receptors, as we've learned, are found within the gut, and activation of these receptors can reduce intestinal 5-HT release. As already mentioned, the mechanism of CBD within the ECS is a bit unclear. It does not bind to CB1 or CB2 receptors directly, but rather may act as a non-competitive allosteric modulator of CB1 receptors and may also affect ion channels, other novel cannabinoid-like receptors, and enzymes which may be involved in the degradation of endocannabinoids. How are cannabinoids broken down? Well, cannabis is metabolized via the hepatic cytochrome pathway and excreted via the biliary tract into feces, along with urinary excretion of acid metabolites. Because the cytochrome P450 enzyme system is implicated in metabolism of THC and CBD, there is actually the possibility of drug-drug interactions with cannabis use. And this has been observed with anticoagulant medications like warfarin and SSRIs, to name a few, but of course, there are certainly many more. When we look at the pharmacokinetics of inhaled versus oral cannabinoids, we can see not only the quick onset of activity through this delivery mechanism, but also the highest achieved blood plasma concentrations within the human body compared to ingestion. Conversely, though the oral ingestion of cannabinoids may take a considerable amount of time to achieve activity, the plasma concentrations are certainly not as high, though the duration of action is much longer compared to inhalation. Here's just another visual representation of the same figure. Though duration of activity may certainly be longer when cannabinoid products are ingested, there may also be wide variability of absorption from one individual to another, and may be more challenging to find the most optimal therapeutic dose. As we continue to learn more about the pathophysiology of cannabinoids and their receptors, we have now identified other interesting targets of many of the other newly discovered phytocannabinoids, such as CBG, CBC, etc., that may serve other highly important therapeutic benefits. When looking at the potential therapeutic uses, and although I appreciate Health Canada's optimism, we need to be extremely cautious when recommending cannabis for many conditions, given that higher quality studies remain to be completed. This is really to ensure that we can truly and accurately provide recommendations to necessary patient populations in the future without predisposing them to unnecessary harm. And of course, Health Canada has an extensive list of further recommendations, but we have to be mindful that data might certainly be lacking with many of these conditions. But to briefly comment on the consideration of incorporating medical cannabis into your patient's care plan, it is important that a number of safeguards are needed to be put in place to minimize unwanted harm. This may be in the form of conducting a urine pregnancy test in women who are potentially of childbearing age to ensure that they are not pregnant and to absolutely avoid exposure and transmission of cannabinoids, given that this is known to occur when being consumed. For patients with significant mental health disease or a strong family history, it's vital to screen individuals for symptoms who may not yet be diagnosed, or those who may be at a high risk of developing mental health disease after beginning treatment, as these individuals may negatively experience adverse outcomes with cannabis use. When counseling patients about cannabis use, it's important that they know that it is not a one-size-fits-all process or approach, and rather we need to take an individualized and tailored approach when considering to incorporate this into their care. Now, given that this is supposed to be a basic and general lecture on cannabis, I won't go into much more detail about how to prescribe and titrate cannabis, but rather highlight some key and important pieces of information that I think are vital to take away. But what is important to know are the relative contraindications and or cautions about cannabis use. So typically, one should avoid recommending cannabis use in individuals under the age of 25, as the brain is not fully developed and that adolescents may be at a greater risk of developing undiagnosed mental health disease, especially if they have an unknown genetic predisposition, which may in fact be worsened after cannabis use. Patients who have a known history of substance misuse are naturally at a higher risk of developing cannabis use disorder as well. As mentioned, pregnancy planning, pregnant or breastfeeding, as cannabinoids can be transmitted through the placenta and breast milk. Mental health disorders, as this is obviously evident that consumption of mid to high THC-based products may exacerbate symptoms such as psychosis or paranoia. Occupational safety sensitive positions like heavy machine operators or bus drivers may experience euphoria or somnolence as a result of cannabis use. Patients with pre-existing or recent cardiovascular disease, as high THC-based products can stimulate a sympathetic response, causing tachycardia, hypertension, can promote atherosclerosis, can also interact with anticoagulants, antiplatelets, and lead to negative outcomes. And lastly, patients with severe liver and kidney disease, as we know metabolism and excretion is largely through these organ systems. So the longest prospective cohort study that we have is unfortunately with an N of 3. Now, these individuals may or may not be familiar with you. But with all kidding aside, we do have some good data, which I'll briefly summarize to make everyone's lives actually a bit easier. And my good friends Martha and Snoop here. So aside from one of the most recent and robust systematic reviews, which was published in 2017 in the National Academies of Science, Engineering, and Medicine, which I will soon present, there have been many other varying studies evaluating the use of cannabis for medical purposes, which I'll not go into the details about, and rather have summarized their collective findings here. That is, cannabis was shown to result in improvement in most symptoms, though this was not always statistically significant. There were a number of course, adverse effects observed, and the studies were of varying quality. As mentioned in 2017, the National Academies reviewed more than 10,000 abstracts from 1999 to 2016, where they ultimately concluded that and presented 3 themes in which they provided and described conclusive or substantial evidence for the use of cannabis.
I thought of it. He went.
Oh, I thought there was maybe a question. But essentially, the National Academies had sort of come up with 3 different themes: substantial or conclusive evidence for the use of cannabis in the treatment of chronic pain, CINV or chemo-induced nausea and vomiting. There was moderate evidence with respect to fibromyalgia and sleep disturbances, and limited evidence of efficacy for use in appetite and weight loss associated with HIV/AIDS patients specifically. Here's just a visual demonstration where we have relatively good data to support medical cannabis use in very specific conditions on the left, and on the right where there is promising and exciting work being done in other diseases, but data and higher quality evidence are still lacking. In terms of drug-drug interactions, there have been some studies that have looked at this specifically with certain agents that either found a potential interaction or lack thereof. For example, cannabinoids, particularly THC and CBD, in conjunction with warfarin use were noted to cause an elevation in INR and potentially increasing the bleeding risk. This was also observed in the pediatric patient population out of the GW Pharma study evaluating the use of CBD in patients with epilepsy, particularly those patients who suffer from Lennox-Gastaut syndrome or refractory or recurrent seizure disorder. And this was, again, in conjunction with the use of clobazam, which is a benzodiazepine. What they found from the studies essentially was that CBD had increased clobazam levels when taken jointly. Lastly, with respect to anti-neoplastic drugs such as immunotherapy, concurrent use of cannabis may reduce efficacy of immune checkpoint inhibitors such as nivolumab, as was evidenced in this study by reducing response rate to this treatment without negatively affecting progression-free and overall survival. This was published actually by one of our ACS colleagues, Dr. David Mary. The bottom line is that cannabis is not a benign substance, and it can certainly interact and affect a variety of other essential medications. And thus, it is imperative to counsel and discuss these potential risks with your patients first. This here is just a basic list of the many common drugs that can either increase or decrease THC levels within the body. And so it again is equally imperative to be mindful in not only screening, but counseling your patients about these potential drug-drug interactions with cannabinoid therapy to avoid unintentional and unwanted harm. Most people who use cannabis, when we look at relativeness of addictiveness, most people who use cannabis do not develop problems with dependency or dependence. Data examining recreational use suggests that 9% of adults who use cannabis develop a dependence, while that number rises to 17% for those who begin using before the age of 18. Again, one of the other relative risks and contraindications of using or recommending cannabis in individuals under the age of 25. But these levels of dependency are significantly less than for nicotine, which is estimated to be at around 68%, alcohol 23%, and cocaine 21%, while they are similar to reported levels of dependency for anxiolytics such as benzodiazepines, being around 9%. Many clinicians are, of course, concerned that patients who use cannabis will become addicted. There are no studies that look at the rate of addiction in patients who are prescribed medical cannabis as compared to those using it recreationally. Now, given this, information about rates of dependency and addiction are only based on really recreational users. Medical users are different from recreational users in a number of respects that may influence the rate of developing dependency and a use disorder. These include the strength of the product and the intention for which cannabis products are used. Medical patients want to improve symptoms, while recreational users may seek relaxation, enhanced creativity and focus, or just enjoyment. With respect to side effects of medical cannabis use, the most common reported symptoms were dizziness, cognitive issues, drowsiness, and fatigue having the highest odds ratios, as evident here. Euphoria has also been reported to be a common and sometimes desired side effect. Of course, who doesn't want to be experiencing some euphoric effects? But where toxic psychosis, paranoia, and tachycardia were reported to be actually quite rare effects and likely being experienced with THC-dominant products and higher concentrations. Lastly, though it is essential to always practice with an evidence-based practice mindset when it comes or when considering any type of medical therapy, albeit cannabis, it's also important to incorporate clinical expertise, best research, including your patient's values and preferences when guiding treatment decisions. As sometimes your patients may not necessarily want or have the expectations of curing their disease, but rather just improve their quality of life by reducing symptom burden, perhaps limiting the need of other pharmacological agents, and or just wanting to improve function and do a bit more dancing like this lady here. Lastly, just some take-home points. Both exogenous and endogenous cannabinoids play a vital role in maintaining homeostasis within the ACS, along with CB1, CB2 receptors. There is, in fact, an abundant pathophysiological evidence to support the health benefits with cannabinoid receptors or therapies. There's also good quality of evidence to support medical cannabinoid use. Of course, be mindful of the cautions or relative contraindications with respect to cannabis use, including the potential for drug-drug interactions. Ensure safeguards and screening tools, as these are necessary before initiation of treatment to minimize and avoid harm. Lastly, again, the purpose for considering medical cannabinoid use is to improve quality of life, functionality, reduce symptom burden, and possibly the need for other pharmaceutics like opioids or benzos, etc. Just briefly about our organization, the Association of Cannabinoid Specialists offers a variety of evidence-driven courses for cannabinoid specialists and other allied health professionals that can further prepare you to be a competent and confident practitioner to better support your patient's needs. On the left here is our organization's president, Dr. Jordan Tischler, who is a Harvard-trained physician and faculty member and is doing some exciting things there on cannabinoid medical education curriculum development. We also have our own digital clinical reference library that makes access to important and relevant articles very easy and is constantly updated by our own experts. And lastly, I just want to thank you all for coming out today, and I hope you gained some new knowledge and information about medical cannabis. And I'm certainly happy to take a few questions, but also happy to take and respond to any sort of queries via email as well. I'm happy to provide my email address. So feel free to pop in any questions in the chat or ask me directly.
Yeah, that was awesome. Thank you so much, Suraj, for coming and doing this. This was a great presentation. And like he said, if anyone has any questions, put them in the chat, raise your hand.
Yeah, and even suggestions. So this is one of the one of the many few of the educational series that we've completed, and certainly our mission is aside from supporting patients and organizations and governments in furthering and improving access to cannabis, is to really educate and provide information and knowledge to the masses, whether it be practitioners, patients, etc. And so we welcome any other subjects or topics that you would like us to maybe possibly present in the future. We certainly welcome that. And I see a couple of questions here. There we go. Okay, so let's see here. I'm gonna pull up. So from Orlando, thanks so much for your contribution, Orlando. So what studies have been toward MS? So I think it's a question from Justin. So again, there are a number of studies of varying quality. If you look at the National Academies of Science and Engineering from 2017, much of their sort of evidence that was found and sort of substantiated and recommended within their conclusion was really with respect to MS spasticity. Again, what I would often suggest is going back to the original source. You can look at the articles in further detail, but really they found the greatest effect in reducing pain or spastic symptoms related to MS. And that could be, again, in a sort of a variety of cannabinoid concentrations. And so the doses and the routes of delivery I don't have directly at my fingertips right now. But again, a lot of the data has been quite mixed. I think what we're hoping and centers like McMaster and so forth are trying to produce higher quality studies, especially randomized studies. So I think we'll get more data as time goes by. Are there any circumstances where you would not consider bipolar disorder contraindicated? Yeah, I think so. Really, I've had many patients in my practice who either suffer from various types of mental health disease, whether it be bipolar, schizophrenia, generalized anxiety disorder, et cetera, or substance misuse history. I think the most important thing first is to ensure that they are in fact supported by a mental health practitioner, whether it be a psychiatrist or some other mental health expert or provider, that you get the approval and certainly make sure that they are aware that if a patient is being referred to you, let's say not necessarily for bipolar disorder or symptoms related to that, but let's say for chronic pain and they have an underlying pre-existing mental health disease, it's important that you sort of kind of inform them that you are perhaps maybe considering to introduce cannabinoid therapy, whether it be THC or CBD or something non-psychoactive. I think that's the first step, and that's typically what I do. Is I will reach out to their mental health providers. One is assuming that they are well supported. Two, that they are on either first line therapies, and three, again, being mindful. What is the rationale and the decision to maybe consider phytocannabinoids as part of their care plan? And then which type of cannabinoid to use. And so, again, I usually will take an approach of using non-psychoactive, cannabinoids such as CBD rather than THC, as we know that THC in higher doses can in fact potentiate anxiety symptoms or maybe perhaps lead to manic episodes. But what we see is that there is data to show that low doses of THC may in fact have anxiolytic effects. And so I think the first approach is consulting, ensuring that the other providers are aware of this patient's request to consider authorization or use. Two, ensuring that they are well followed and well supported, and perhaps also ensuring that they are on appropriate pharmacological agents. And then considering maybe the least harmful cannabinoid as part of the regimen. So that's the approach that I would typically take. Here we go. Let's see here. There are also several MS studies. I'll be in the clinical reference library. Yep. Thank you, Kelsey. Yeah. So one of the other important factors is with respect to a lot of these questions we've been quite meticulous in finding the highest quality evidence and publications out there and incorporating them into our clinical reference library so that it's much easier for people to pull and retrieve and look at the most current evidence, especially when they have a patient and they're considering its use if they feel comfortable with prescribing, or two, are uncertain and there may be some concerns with respect to new symptom presentation that might be related to the cannabis or their existing disease or drug-drug interaction. So I think using our clinical reference library is something that we've put a lot of effort in building to really create a very structured approach with helping practitioners be able to manage and support their patients. And I think hopefully if there's any other questions, feel free, but again, thank you all for coming out a little bit early. And if there's any other subjects or topics for the future, please let us know. You can email Kelsey, our team members at ACS as well.
Yeah, thank you everyone for coming. If there's no more questions, we can wrap it up or we can open it up for discussion as well. We do have a few more minutes, so floor is yours.
Oh, we have a psychiatrist on here. Dr. Godesar is a psychiatrist in Canada. Glad to see that she's on here as well. So with that being said, again, thank you, Kelsey, Sarah. Thank you to all of the people that joined today, and look forward to seeing you in the future again.
Thank you.
Great, thank you so much. Good night,
Okay.
everybody. Thank you so much for coming.